Yeah, this is a very timely and interesting question, and I believe you are referring to the enormous efforts that we have seen over the last 20 years in finding new biomarkers that would guide us to improve diagnostics, to improve risk stratification, to show progression or regression, etc. And I would answer the question, we are not at the dead end, but we have faced a number of problems that we have not yet solved adequately. So imagine at the beginning, there was a whole panel of biomarkers. So almost every week you would have a new biomarker in the literature. And at some point in time we have realized that simply showing an association between a biomarker and the outcome is not enough if it comes to clinical utility. So for clinical utility you need a number of other requirements where you have to show that you really discriminate between healthy and diseased, and that you can reclassify patients in terms of risk stratification. And that has taken a while to improve the methodology. And also a number of these biomarkers that are of pathophysiological interest are not robust enough to be introduced in the routine clinical setting because of pre-analytical issues and a couple of others. So because of this, only relative few biomarkers over the last 15 years have made it into a clinical routine. And I think the best example is troponin. Troponin are extremely useful for us cardiologists to diagnose acute coronary syndrome and also tell us about prognosis. In addition to this, markers of hemodynamic stress, like for example BNP or N-terminal pro-BNP, are important to give us an idea about the functioning of the heart. And finally, markers of renal function. We have discovered those that go beyond creatinine in terms of precision, etc. So a couple of things have happened, but out of these many biomarkers that have been in the pipeline, only very few today have made it into clinical practice. There are certainly, I just mentioned a couple of them that have been established meanwhile, so troponin also being established. Still a lot of people are working on newer assays, on higher sensitivity assays. They try to improve risk algorithm, etc. So a lot of research is still ongoing. In terms of novel biomarkers, there are a number around there still under consideration, like for example GDF15, which is a member of the transforming growth factor family, but consistently it could be shown to be associated with hard cardiovascular endpoints, namely cardiovascular death or total mortality. And more recently, a Swedish group from Uppsala has shown that it may add significantly to established risk score in predicting bleeding in patients on oral anticoagulants, for example. So this is a very important question. And beyond that, I mean, new technologies open new horizons, for example, lipidomics, metabolomics, proteomics. And just to mention one example out of the lipidomics area, so-called ceramides. Specific lipid particles have recently shown to reasonably well predict cardiovascular disease and add to existing biomarkers. And so they have been tested in several populations, and they are already being offered by a US company, so you can order this test. Also an important question, and similar along the same lines what I mentioned for blood biomarkers. There was also development in terms of imaging technology, and we have a number of imaging technologies. Yet similar to the other question, only few have made it as a routine. So for example, for years we were looking at the carotid artery, measuring the so-called intermediate thickness complex. But this has changed over time. More and more studies came out, and we have really seen that this is not as reliable as we initially thought. In terms of other imaging methods that are suitable for risk stratification in the primary prevention setting, more recently calcium scoring came up, and this seems to be fairly reliable with very little, at least these days, with very little radiation. So you can use it in patients at intermediate risk where you are not sure what to do with those in terms of the classical risk factors. There are, in addition to these non-invasive imaging methods, there are also invasive imaging methods, but they are not suitable for screening. You use them in specific situations to evaluate high-risk subjects or patients during interventions, for example. Yeah, this is a fairly complex question, and I think it has at least two sides. And one side is new technologies to create new clinically relevant biomarkers that are reasonably robust for the clinical situation. This is one hand. And the other hand, obviously, is to improve our bioinformatic skills, so to say, to really assess adequately and digest that information that we get from these omics technologies. For example, there are several platforms available where you can measure almost 200 metabolites, different pathophysiological pathways that are all of importance in terms of atherosclerosis. But to adequately manage these data and digest them and then come up with a useful final panel that may be clinically applicable, this is the question. And so besides new technologies to detect new markers, we also have to improve our statistical skills, our bioinformatics skills, to come up with a final clinically relevant set.